EndoWheat means that we are not going to connect the fenestrations to the coronary arteries. EndoBentall, you have branches that you need to connect to the coronary arteries.
Good afternoon, Professor Haulon. I'm Mafalda Massara, vascular surgeon in the unit of vascular and endovascular surgery at the great Metropolitan Hospital of Reggio Calabria in Italy. In this afternoon, I want to ask you about a very interesting topic for the next PVI 2026 as the endovascular solution for type A aortic dissection. First of all, I want to ask you which is the real patient unfit for open surgery?
So that's a very tricky question, Mafalda, but so thank you for the invitation, and I'm very happy to participate to this interview. I think that there is a subgroup of patients that are at high risk for surgery in the setting of an acute type A dissection. One reason for that is age. We know that above 80, the result of the surgery is not that good. Another reason is those patients with malperfusion. Malperfusion can be to the supraortic trunk, and the patient can have a stroke, or a malperfusion to the renal visceral aorta or lower limbs. And then you have the usual risk factors, the COPD, the renal insufficiency. And so that there are scores that can tell you if a patient is at high risk or very high risk of open surgery. And that's why there's a limited number of patients that currently can undergo an endovascular repair. Most will be better treated with an open approach. But we have a bias in my center, is we get all those patients that are turned down for open surgery in the Paris area to my center, because one of the CT surgeon has developed a specific technique, which is the wrapping technique. So he repairs type A dissection without using a cardiopulmonary bypass pump. And so that's why we have quite a high number of those patients that are turned down for open surgery. And that's why we tried new options without opening the chest with an endovascular minimal invasive approach.
Okay, thank you, Professor. And now I want to ask you about the project of EndoWeat and the difference with the EndoBentall.
That's an excellent question. EndoWheat means that we are not going to connect the fenestrations to the coronary arteries. EndoBentall, you have branches that you need to connect to the coronary arteries. So we perform EndoBentall if the patient has a root aneurysm. But then there's a very important limiting factor is the coronary artery anatomy. A lot of patients have a short main trunk on the left side, or a very reduced diameter right coronary that makes a 180-degree angle, or they can be diseased. So many patients are turned down for an EndoBentall. Now, the EndoWheat has been developed specifically for acute type A dissection, but only for dissections where the entry tier is distal to the STJ. And the idea of the EndoWheat is to get the endograft all the way to the annulus, and having in the aortic root fenestrations that will continue to perfuse the coronary artery. And this will bring the graft all the way to the STJ, and the graft will have wall contact all the way to the STJ. So that's why we can exclude patients with acute type A dissections, but only if the entry tier is distal to the STJ.
Okay. And about the valve, what do you think?
So we have made a lot of testing in the lab. We did a lot of 3D prints of dissected ascending aorta, including the root, the coronary arteries, and the valve, the left ventricle. And we've worked for the last 2 years with Cook on a specific delivery system, which includes both the valve and the endograft. The nice thing about this system is you don't need remote access. You don't need to go transapical. You don't need to come from the axillary or carotid arteries to get the valve. But you need to insert the valve system inside the delivery system of the endograft. And it actually works with all the valves that are currently available on the market. But we have decided to perform our first study, a prospective study that is starting very soon, with a balloon expandable valve because it's quite it's faster and to position in this specific setting of the EndoWheat, and it will secure the graft at the level of the LVOT. It will just with its radial force, make sure that the graft is nicely fixed at this level.
Okay, it's a very great idea and a very big project. And did you think this project has an off-the-shelf solution? Is it
Exactly,
correct?
and that is a very important point because the idea is that when the acute type A dissection arrives, which is 24/7, usually it's not at noon, it's more at midnight or in the middle of the night or during the weekend. We will have 3 different devices that are off the shelf with the 3 different diameters according to the valve diameter. And depending on the patient's anatomy, we'll use one of those 3. Now, we made an anatomical study looking at 200 CT scans of patients with acute type A dissection, and we believe that we could treat about half of the patient with this solution. So it means that half will not be included, enrolled in our study.
Okay. Do you think 24 French device can be a limit to treat
So
this patient?
it's a good point. In dissections, usually access is not an issue. It's more for a patient with PAU or a patient with some atherosclerotic aneurysm that also have PAD and some iliac that are diseased. So in most patients, I think that 24 French sheath will not be an issue. Having said that, I'm sure that in little women that might become an issue, and so we will have to check access. But in the study I was quoting, access was actually never an issue. The issue was more about the valve, the annulus that was too large, or the entry tier of the dissection that was in the root. That was the main reason for turning down. And to finish with the profile, because I think it's a very interesting point you're raising here, Mafalda, I think that in the future, we will be able to reduce the profile of the delivery system because the next generation TAVR devices will come pre-mounted, pre-crimped, and with better profile. So I think currently we are limited by this, but I'm sure that in the coming years we will be able to reduce to 22 or 20 French the profile.
Okay. And about arteries accesses, do you recur to femoral, radial, or other access?
So we will access one femoral and the right radial. The right radial will give us a pictal catheter that will be positioned at the level of the root. And then we will push the delivery system over a wire that is in the left ventricle. Once the delivery system will arrive at the level of the left ventricle, we will push a second Lunderquist, which is preloaded into the valve delivery system. So at one point, you have two Lunderquists in the left ventricle. So we will have to be very careful about the position of those Lunderquists. And then you release the endograft. The endograft has very aggressive diameter reducing ties. So when you release it, you don't need to start rapid pacing. At this stage, the valve is just next to the endograft. So you start rapid pacing, release the reducing ties, get the nose cone of the endograft and its nanoquist back, and advance the valve. So the rapid pacing time will be between 30 and 45 seconds, which is okay. And there's only 10 centimeter for the valve to progress in the graft towards the landing zone.
Okay. I think it's a very interesting point, but I think it's necessary a very, very good team with cardiac surgeon, vascular surgeon, perfusionist, and anesthesiologist.
I'm 100% in line with you. It is very, very important that we vascular surgeons don't start making those procedures alone. So you need a cardiologist that has a huge experience in structural heart procedures, so a very large experience with TAVR. You need a cardiac surgeon to be involved because you can have tamponade. You sometimes will need to get the patient on pump quickly if you have a major valve insufficiency. So it's really a team approach. I think it's very important that you raised up this point because I really want to make sure that our colleague vascular surgeons don't think that this procedure can be performed alone. It is very, I think it would be dangerous to do it on our own, and it really requires a multidisciplinary team.
Okay, Professor, I think it's okay for today, and see you at PVI 2026. It was a great honor for me to have the opportunity to interview a professor as you. Thank you very much.
I thank you because your questions were very specific, and you have a good knowledge and you understand what is important. So I really enjoyed our discussion, and I really look forward to seeing you in Paris in the Louvre for PVI 2026. Thank you so much.
Thank you. Bye.
Bye-bye.